It's important for physicians to be involved in this because we look after patients and families with many of the conditions that give rise to the question of medically assisted dying. Well, of course, the oncologists are the ones that we think of first, but we need to also remember that our respiratory physicians look after people with end-stage lung disease, cardiologists with end-stage heart disease, rehabilitation specialists and neurologists often look after people with long-term degenerative neurological conditions. And so we really care for those patients who might be asking for medically assisted dying. In addition, I think we've got a broad range of experience both in the community and in the hospital sector, so we've got a lot to contribute to this discussion.
I think as physicians we're at the coalface. We are caring for people who are dying. Most people die in hospital and we are seeing them day in, day out. So we want to be able to give them the care that they need and offer them support and their family support, but still maintain trust with them. I think that's probably the most important element to this issue being a physician, is to maintain the trust of my patients and their families.
If or when assisted dying in whatever form is approved and legalised in this country, the expectation is that physicians will become an active part of that process. And so it's very important that we have a position, that we have discussions, we listen to each other, and we project our thoughts and our considered beliefs to the people that are making the decision. So they don't just assume our role.
So from my travels to jurisdictions where medical assisted dying was legal, I think the main challenges for physicians varied between the jurisdictions that I went to. So in the Pacific Northwest in the US, really this legalisation was thrust on physicians with or without their sort of, I guess, support for legalisation. So there was a little bit of catch-up to be done from the physician perspective. Some of the issues that have been the most important thing for patients in legalised jurisdictions include loss of autonomy being number one. Number two would be loss of the ability to do things that make life meaningful for patients, and most of that relates to functional independence. And the third most common, I guess, reason for people accessing legalised assisted dying in those legislations is loss of dignity, though dignity is undefined.
As a geriatrician, some of the challenges that we face will be about decision-making capacity. Is this person really able to understand the full extent of the question, the consequences of their action, both for them and for their families? So decision-making capacity will be a key issue in this. We also have concerns that older people may feel pressured.
I think misconceptions around end of life and about death and dying may preclude people accessing the care that they need, not giving them the opportunity to have their needs assessed and met. So, for example, not understanding that in many situations pain can be optimally treated, it can be anticipated and the correct management implemented early on. As a palliative medicine specialist, I think the key issues for my patients have been borne out in the evidence over many years. So the same issues recur again and again. Number one would be to be comfortable at the end of their life physically. Number two would be not to be a burden on others. And I think often we don't appreciate this till very late in the piece. The third, I think, is strengthening relationships with loved ones, significant others. Many patients want to have the opportunity to have meaningful conversations, and they need to be able to prepare for that. And that means appreciating when they are heading towards the end of their lives.
As physicians, we feel passionately about this because we care about patients. We have learnt how to look after them, to provide support for them, to cure and manage their illnesses. And now we're being asked to take a completely different line of care.
Common ground for caring at the end of life would, I hope, normally be that physicians do not abandon their patients at the time of their greatest need. I think that the specific issues of how medications are used, the circumstances in which they're used, those are the differences. the commonality is being with the person, staying with them, staying with the family, walking that road with them, holding their hand, sitting beside the bed.
There are some key learning things that policymakers should take from the experience overseas in jurisdictions where assisted dying has been legal. I think the number one thing to think about is that in each context, the values that drove legislative change were critical in informing how legislation should look if indeed the Australasian context decides to go down the path of legalisation.